A very good morning, everyone. So today's lecture is on relining, rebasing in complete dentures and the denture repair issues. So by the end of the lecture, you should be able to describe the various techniques involved in denture repair, relining and rebasing. Then also identify the potential problems associated with denture repair, relining and rebasing. So to define, relining is a procedure used to resurface the tissue area of a denture with new base material to make the denture fit more accurately. But whereas rebasing is a process of replacing the entire base material of a denture and only the original teeth and their arrangement remain. So according to Shari, it consists of replacing all of the denture base with newer material. So when a patient walks into your OPD and they give you general complaints, a complete denture patient walks in and he says, the denture is loose and, there's general soreness and inflammation, then, this chewing inefficiency over a period of time, patient is not satisfied with the aesthetics. So when they come up with such kind of complaints, you have to re-examine the denture. You have to, spare some time, take a look at the denture, try to identify and analyze what is the complaint of the patient. So, what are the main objectives of relining or rebasing? First thing is to ensure that you establish a correct relation of the denture to basal tissue. Then restore stability and retention. Next, restore lost occlusal and maxillomandibular relationships. And next is your indications. So when do you say that this patient is good for relining and rebasing? When you see that there is continuous alveolar resorption, then there is a decreased BDO, then the patient has been given an immediate denture post extraction, then the patient has some socioeconomic constraints where they cannot afford to go for a new denture, and also if the patient is having any mental illness. So in those cases, we prefer doing a relining, which is much more easier when compared to doing the 5-step procedure of constructing a new denture processes. So what are the contraindications for such kind of conditions like relining and rebasing? That is, if the patient has an existing temporomandibular joint disorder, if you see that the inflammation of the soft tissue or the sore spots, they have not healed over a period of time, or there is any existing pathological condition, there is a malpositioning of the artificial teeth, there are multiple fractures and severely attrited teeth of the denture, then if there is an unfavorable occlusal plane, deflective occlusal contacts, then BDO is decreased more than like 3 to 5 mm, sorry, must be increased more than 3 to 5 mm, and the interocclusal space has also been collapsed. So if these are the cases, then you might not consider doing relining or rebasing. That is when you have to look at fabricating a new processes. What are the other general considerations prior to relining or rebasing? You should ensure that the patient has a satisfactory vertical dimension of occlusion. The centric occlusion should coincide with the centric gradation. Patient is satisfied with the aesthetics and the speech. The oral tissues are healthy and don't have any issues. Then adequate denture base extensions have been made and there are no under extensions. That is, you can consider doing relining and rebasing. The different materials that are used for relining and rebasing are PMMA, modifications of PMMA, then your tissue conditioners or your soft liners, and silicone materials which are chemically activated or heat activated. So before you begin with relining and rebasing, what are the pre-treatment procedures? So in your pre-treatment procedures, the first thing that you have to ensure is that there is adequate tissue rest. So the denture has to be taken out from the patient mouth and left in the patient mouth for at least 2 to 3 days, so that the soft tissues come back to its normal state. You know that when you place a denture, the soft tissue and the underlying bone is under continuous stress, right? So in those cases, you should allow some amount of soft tissue rest. Then you should also educate the patient to massage the soft tissues 2 to 3 times a day to simulate good blood supply and aid in recovery. So when do you use a tissue conditioner? When you see that the patient cannot leave the denture for a long period of time and they have some social gatherings where they cannot avoid wearing the denture, and there is extensive tissue abuse, then in that case you have to use a tissue conditioner. And also ensure that you give an appointment after 3 or 7 days, so that the tissue conditioning material will have to be replaced. You, once the patient comes back for his second appointment, you examine the tissues and you ensure that the condition of the soft tissue is healthy, or it needs any kind of a tissue conditioning once again. So in that case you take a call and you make the tissue conditioner. So next thing is that the surgical management. So in your surgical management, you have to ensure that and see if there is any excessive hypertrophic tissue, something like an epilus fissuratum or a bulbous tuberosity, or any soft tissue overgrowth like a polyp or anything of that sort. If you have noticed in the undersurface of the denture, those will have to be surgically excised, and the denture itself can be used as a surgical splint. So next thing is your denture preparation. This is the most important step. So in this step, what you've got to do is you take the denture, you prepare the extensions of the denture, remove at least 1 mm over the anatomy, over the border areas and the tissue surface area. 1 mm is relieved. Then try to remove all the undercuts. Just check that there is no occlusal disharmony, and ensure that the PPS area is also sealed. And once there is adequate space for the impression material, then you go ahead and make the impressions, or you follow the different procedures. So the treatment can be carried out in 3 ways: your clinical procedures, laboratory procedures, and your by using your chairside technique. So in your clinical procedures, there are 2 ways, that is static methods, functional methods. In static methods, it's your open mouth technique and closed mouth technique, and next is your functional method. And next is your in your laboratory procedures, you have articulator method, jig method, and your fast method. So let us look at one by one what are the different techniques. In your static method, in the open mouth technique, both the maxillary and the mandibular dentures can be relined and rebased at the same time. So the denture itself is used as a special tray for your secondary impression, and preferably we try to use zinc oxide eugenol as a material of choice. And with the dentures in the patient mouth itself, a new centric relation record is obtained. So this is how you remove 1 mm of the denture borders. It is supported by green stick compound. The border movements are carried out, and then the final impression is made with the help of zinc oxide eugenol. So the advantages is that selective trimming, it helps to make selective pressure impression. Then interocclusal record is reliable, and also because the denture bases are quite stable, to obtain a jaw relation record is much easier. And the only disadvantage about this technique is that there's a lot of clinical and laboratory work that is involved. Next, coming to your closed mouth technique. In this, the relining cannot be done simultaneously for both the maxillary and the mandibular dentures, right? So as mentioned earlier, like your this thing, it has to be done separately, but it's the same procedure. So you use the denture base, the existing denture itself to do the impressions and the centric relation record. The denture preparation is as similar to what I've explained earlier. Border molding has to be carried out with green stick compound, and then the impression has to be made with zinc oxide impression material. So it is done one at a time. So once it has been carried out, the master cast is obtained, and you will reline it with the help of a newer acrylic material. So the advantages is that because you are trimming the denture and making space for the impression material to flow into that, there will not be any kind of occlusal interference. Sometimes if the lower denture and the upper denture are placed at the same time, it might cause any kind of gliding, which will cause disturbance of the recording of the impression surface or the tissue surface. Yeah, and next thing is you can obtain a separate interocclusal record and keep it aside and do a new jaw relation record. So for verification, you can just have a look at the existing record. So it is possible to verify it. And since interocclusal record is made with the help of with a plaster, It is more stable and easier to do. And only thing is that in this technique there will be increased number of clinical steps, and of course the laboratory time is also increased, so performing all these procedures at one go is not very easy. So next, coming to your functional method. In your functional method, what you do is you use the existing dentures, reline it with the help of a tissue conditioning material, and there is not any laboratory procedure that is required for the functional method. So how do you use this tissue conditioners, and what are the characteristics that tissue conditioners should be having so that you can use them for relining? It should be easy to use, it should have excellent fitting for the complete dentures, it should be capable for retaining for many weeks without any changes, it should have good dimensional stability, and also have good bonding to the underlying dental resin base. So how do you do the relining with the help of a tissue conditioning material? So occlusal errors, you have to ensure that there are no occlusal errors and the centric relation of the existing denture is correct. Only then you can reline it with the tissue conditioner. So the tissue surface is prepared carefully, the acrylic material is just removed and accommodate tissue conditioning material, and then after that the tissue surface is dried up, and a thin layer of this tissue conditioning material is flowed and coated over the area and placed in the patient mouth, and the border movements are done, and after which the denture is inserted. Once the then you have to guide the patient to bite into his centric relation record, so that you wait with the patient biting in the centric record and the material will set. So once the material has been set, slowly remove the denture. Whatever excess material is there, it has to be cut with the help of a surgical scissors or a blade, and trimmed and polished. So in case if there is a poor recording, what you have to do is again use green stick compound and do the recording once again. So after 3 to 5 days, the denture has to be examined if there are any areas which are not recorded properly, and if the healing is happening, or if there's any abused tissue which is not coming back to its normal state. So you have to recall and revisit the patient. So once you have ensured that the tissues are okay, that is when you schedule the appointment for the impression, which can be taken with the help of zinc oxide eugenol on the tissue conditioner. So your tissue conditioner material will not be removed. On it itself, you're going to make the zinc oxide eugenol impression material, and a master cast is prepared with the help of that impression. And if you're doing it on a semi-adjustable articulator, at that point you have to do a face bore record, after which the laboratory procedures will be carried out. Then what are the advantages? Because you are using a tissue conditioner, you are helping the unhealthy tissues or the abused tissues to come back to its normal condition, and a functional impression that incorporates the natural movements. So because you are placing it and doing the normal natural functional movements, it helps in recording the accurate movements, and there are no problems with the recordings. Yeah. So next, coming to your laboratory procedures. So in your laboratory procedures, you, as I mentioned, articulator method, jig method, and your flasking method. So in your articulator method, the first thing is that you use your denture itself and you make an impression. It's either made with the help of your light body impression material or your zinc oxide eugenol. Then you make the master cast with the help of dental stone as in the picture. So once your cast has been obtained, what you do is, except on the occlusal surfaces of the teeth, the rest of the area is covered and coated with modeling clay, and this upper member is mounted to the articulator. So once the upper member has been mounted on the articulator, what you are going to do is, on the lower member you will have a platform of plaster that is created. Yeah, you will you will take the help of modeling bags and create a hollow space and fill it with some amount of dental plaster or dental stone, depends upon the ease of the clinician or the technician, and this upper member is made to come and fall into the material which is not yet set. So 2 to 3 of deep indentations have to be made on the lower jig, so that this is coming in contact with the plaster. So once the plaster has been set, then both of them have to be separated, and you have to ensure that there are very clear cut indentations on the platform of the plaster. So then that is when you separate the denture from the master cast. Then the inferior surface is prepared with the help of an acrylic to receive the new acrylic material. Borders are also trimmed 2 to 3 with the burr. The frenal notches are deepened with the help of crosscut burr, and after that it is cleaned and or make sure that there are no acrylic materials. Then also preparation of posterior palatal seal must be made either using the scraping technique or fluid wax technique, or if the PPS area has been recorded in the earlier technique, then it's not required to redo again. So you paint the master cast with the help of a separating media, and then you take the auto-polymerizing resin, mix it properly without any kind of air bubbles, tap it, and then that is coated on the undersurface of the denture. So once it is coated on the undersurface of the denture and you ensure that there are no voids, that is placed back on the master cast on which there is separating medium, and then this jig is closed together. So the indentations have to be clearly seated in their own demarcations, and once you have seen that the material is set, it is placed in a pressure container for at least 30 minutes, and after the 30 minutes are over, you take it out, and this is how your denture will look like. So the excess flash of material that you see from the denture borders has to be clearly and carefully removed, and please ensure that you will not remove the denture borders. It has to be trimmed and polished, and as seen in the picture, you can see that the new relining material or the rebasing material has taken nicely the shape of the anatomy you have obtained in your master cast. The next way of doing the laparatory procedure is your jig method. In your jig method, you have ready-made jigs. So in the lower member, you have plaster. After you have obtained you have obtained the impression, you poured the master cast, a base for the master cast also has been obtained. You don't remove the denture from the master cast. The master cast along with the denture in its place will be placed on the lower member as seen in the picture, and again the indentations have to be obtained, and the the jig has to be closed, and the lock nuts have to be tightened. So once it has been tightened, then you again fill up the gap between the master cast and the upper member with plaster and secure that position. So once it has been secured and the plaster has been set, you open it, and with the help of a hot spatula, you slowly remove the acrylic teeth from the existing denture. So once you have removed the teeth from the existing denture, you place those teeth in the indentations of the lower jig. Okay, so once it has been done, then what you do is you adapt slowly a layer of base plate wax to the cast. That is, you take out the original denture base, and you place base plate wax in that. So once base plate wax has been done, you close the articulator, ensure that the wax up has been done cleanly, and once the wax up has been done, the upper member will be demounted from the jig, and it is placed in the acrylizing flask, and this is directly flasked like this, and from here it is the regular flasking procedure that you would have done in your preclinical procedures, right? So when you are doing your preclinical teeth arrangement for complete dentures, you would have definitely used or seen these flasks, right? So you do the first pour technique, then you wait for the plaster to set, apply separating medium, then do the second pour, and once the plaster has been set, you do the dewaxing, and you get the teeth in the other counterpart, and do the wax has to melt, and then pack it with acrylic material. But in this technique, the advantage is that you have the jig over here. So the thing is, after the complete fabrication of the processes, you can still place the denture in this jig, the indentations, and ensure whether there are any occlusion errors. So that is how you do it, right? So next is your flasking method. So flasking method is where you obtain the impression and the denture along with the master cast is invested, and once it has been invested, the acrylic teeth indentations that you see, you will get it on the counter flask, and these teeth you're directly flasking it. You're not using any articulator, you're using just the denture as it is. And once you've got the teeth, so you remove the entire denture bearing area except the teeth have to be placed back in their indentations, and that entire denture bearing area is again packed with acrylic material, like how you do for your regular curing cycles. Yeah, so once the curing has been complete, this excess material has to be cut out and trimmed and polished, and your denture is ready with old teeth but new denture based material. But the problem with using heat cured relines is that the patient will have to sacrifice not wearing the denture for at least a 1 day period, and also next is that reheating the original denture can cause some amount of warpage, and next the process of doing this reheating sometimes might also lead to occlusal discrepancies. That is what you will have to be mindful of. Next, in those cases, what you can also do is use autopolymerizing material, and acrylic resin material is just mixed according to the manufacturer's instructions. Just pour it in that area and close the flask again and allow it to set for at least 30 to 35 minutes. And once you know that the material has been set, slowly open the flask, and then you know that the material has flown equally. Why you are using the flask here in this technique is that even though you are replacing it with autopolymerizing resin, you want to ensure that there is adequate and uniform pressure that is placed on the flask, so that the material will flow into all the surfaces of the denture bearing area. Yeah. So next comes your so that's about your self-cure acrylic resin material, and yeah, you have to ensure that once the curing is done, you have to carefully remove it from the master cast, ensure that there's no what do we say, like the dental stone or plaster on the undersurface. You have to carefully trim it and ensure that you don't over trim it also, so that it will not leave any kind of spots. The next thing is that your chair side technique. So all of these techniques that we have discussed earlier is your laboratory procedures, which involves at least 2 to 3 days of labor, wherein the patient has to also sacrifice the denture and give it back to you, and you will have to do the procedures, right? So but whereas in your chair side technique, once a patient walks into your clinic and says that he's not happy with the fit of the denture and he's been using it for a good amount of time, and that is when you do your chair side procedure. So in your chair side procedure, as you see in this picture, it's more like it's just like your acrylic materials itself. You have to just prepare the denture tissue surface area, just remove 1 mm of that area, to do the instant lining and rebasing, and just place the material, place it in the patient mouth, do the movements, and if there's any excess, trim it off. But it's a very easy procedure to do, and the only disadvantages about this chair side technique is that it's very unpleasant to the patient, and the flow of the material is sluggish and cannot be readily controlled, in contrast to the conventional impression material. Your impression materials can be redone again, but this also can be redone, but it's quite expensive, so you have to be very careful about that. And the time it takes to set is quite high, and sometimes it might cause tissue irritation to the patient. So, and maintaining the occlusion is sometimes difficult, and if the denture is not placed in the patient mouth in the first attempt properly, and if you tend to rotate the denture, sometimes the material will be disrupted. You cannot control the thickness of the border, and how you're going to trim it is going to be difficult. There might be a lot of tissue defects. Then the most important thing is that you might see a lot of porosity, because there might be some voids in that mixture, and if there's voids incorporated, it might lead to porosity. And the last but not the least, the thing is that the color of this materials is not stable. So over a period of time, the patient will come back to you with a complaint that the color is changing, and it looks it's just taking up all the stains of the coffee or any kind of food particles that they're going to take, and it looks very unpleasant. So that is when again you will have to consider redoing it. Yeah. So that's about your chairside technique. And next, coming to repairing of your complete dentures. So when do you consider repairing of your complete dentures? Dentures either may fracture during your function when they are masticating, or if they tend to chew hard bones or anything like that. So if you are on a vegan diet, then it should be okay. But if they consume a lot of meat, sometimes if they are very over enthusiastic and they tend to bite with the dentures, so that is when they might fracture. Yeah. And also that if the dentures they're not handled with care, and you just it just slips out of your hand and it just falls from your hand, then it can also cause fractures. So classification of fractured dentures goes like this. It is about according to the location of the fracture, and next is your according to the extent of the fracture. Based on the location, it can either be midline fracture or any part fracture. And next one is according to the extent of the fracture without broken or missing teeth, or with broken or missing teeth also can be there. Next, according to the timing of the fracture, it can be an early fracture or a delayed fracture. According to the cause of fracture, the operator and the patient. So denture repair can be either tooth replacement, anterior teeth or posterior teeth, or it either can be a fractured denture in which separated parts or non-separated parts have to be reassembled, and repair has to be done. Or if there are any missing parts, then the teeth have to be replaced. So if it is considering midline fracture, one of the most important and the most commonly seen fractures is the midline fracture. That is because of either insufficient relief in the midline, early fracture, or otherwise if there is continuous resorption and there's a crack in the midline, that is a delayed kind of a fracture. So what are the steps? So what we can do is, when the patient walks into your clinic like this with a broken denture, so what you do is, the broken parts are first assembled. They are held together in place with the help of sticky wax. You use some old burrs, and then you use sticky wax, and you secure the denture as it's like in its exact position. So once that has been done, any undercut or any fitting issues, they have to be checked for. It has to be blocked out, because when you're trying to remove it from the cast, it should not cause any issues. So with the help of wax, you block out the undercuts, and on the cast, on the fitting surface, the separating media has to be placed, and you pour a master cast. So that's how your denture looks like. So once your master cast has been obtained, you take the denture and you see that there is a crack over there. So with the help of a straight fissure burr, the fracture edges, you make a small gap over there. They are widened, and after that a dovetail preparation is done on either side of that joint. So once that joint has been prepared like that, then it is the cast is again painted with separating medium, and then the denture area, the area where there is a crack, self-pure acrylic material is placed, and this is secured with the help of rubber bands. Or otherwise, what you can also do is secure it with wax in the peripheral area, so that the denture does not move during the acrylization material. And overall, you can hold the denture secure it with the help of rubber bands. So once it is set, you take it out, you trim, polish, and do it. Yeah. So next one is any part fracture. So if any part fracture, that might be because the denture has fallen out from your hands and there's a crack, right? So there are two types. That is your type 1 fracture, that is no missing part. There might be only a small crack. So if it's a midline crack, that's how you deal with it. And next one is your type 2 fracture with some missing part or lost part. So if you look at this picture, you see that the labial flange of the denture is missing. So what do you do in such kind of cases? You can just make an impression of the patient's mouth with this existing denture and pour a cast, and ensure that this area is recorded properly, and on that cast you remove the impression. Once you have removed the impression material, you can either replace it with some self-cure acrylic material, or it can be placed with wax. Wax up can be done, and then you can do the flasking procedure with your heat cure acrylic material. So you pack it with heat cure acrylic material, then once the curing cycle has been completed, you take it out, you trim and finish it, right? So next is your type 3 fracture, where there is a broken or a missing tooth. So whatever tooth is missing or it is broken, you just remove that area as shown in the picture. So on the lingual side, you have to ensure that there is enough acrylic material that is removed, so that, because without adequate space for the material to hold it, it is very difficult. So then you remove it, and a small dovetail is made, and a tooth of the same size and shape has to be selected. Ensure that the shade selection will be good, because if there is a different shade of one particular tooth, it looks very awkward. Yeah, and it has to be placed in that material, in that indentation. So the height also has to be adjusted in such a way that the ridge lap has to be prepared to receive the tooth exactly in that position. So once it has been placed, what you can do is you have to make a index with the help of a plaster, dental plaster material. You make an index in that area. You place the teeth, and the area below the tooth will be secured with the help of wax. So once the wax has been placed and the tooth is exactly in position, then you can do something like you know the teeth are placed in the exact position, and then on the lingual side you begin to add the self-cure acrylic resin. So once that self-cure acrylic resin is being built up, and the tooth is secure in that indentation where it has to sit at the correct height, on the other side the denture, the index is removed, then the whole unit along with the plaster index is what do we say, flasked, and this plaster index is removed, and you pack that material with heat cure material, and you take it out, finish and polish it. So next, coming to your posterior teeth replacement. So in your posterior teeth replacement, if there is a broken posterior teeth or something, the dentures have to be, the impression has to be made, make master cast, and that has to be mounted on the articulator. So once the mounting on the articulator has been complete, so what you do is you use a round burr and take off the tooth over there, like whatever remnant parts are removed, make a small indentations, and a ridge lap hollow ground is prepared. And once it has been prepared, select the artificial tooth and keep it in that area, and check whether if it is seated properly, and you have to close the articulator to ensure that there is no gap and the occlusion is exactly like how it was with the previous tooth. So once you see that the positioning is correct, that is when you apply a little bit of your self-cure acrylic resin material in that indentation. Place that autopolymerizing resin and place the tooth on the ridge lap area. Seal the tooth on the denture base with the help of a small paintbrush, and close the articulator immediately to ensure that it is cured in the right place. So once it is cured, and your material has been set, that is when you can open the articulator and remove the excess material, trim and polish it. And you can also use an articulating paper and see if there are any high points. If the tooth has not been correctly placed, you can use an articulating paper and check for any lateral disturbances, premature contact points, and remove that, and again you can just readjust it. Yeah. So once you have placed the tooth, what you can do is, with your self-cure polymerizing resin itself, that is rapid repair material, if you're using that material, you might as well just place it in the hot pot, like in a warm water container, so that it will cure the material much faster. Allow it to set for at least 30 minutes, and that is when you do the polishing and repair. Yeah. So that's how your denture should look like after you have finished repairing the denture. You fine polish it and give it to the patient. So in such kind of cases, when there is a small missing tooth and the entire denture is fine, that is when you need to take a call and decide and say that, okay, we are not going to construct a new denture, but a denture repair is just good enough. Yeah. So I hope that you were able to understand all the different techniques. So in conclusion, I would just say that any of these methods that we have been discussing about is just going to give you a satisfactory result. It is never going to be as good as a new complete denture prosthesis. So only if you have the expertise to attempt doing these techniques, you can do it. If you do not have thorough knowledge on how to do the procedures, so then you should not try to attempt such kind of things. Yeah, so I hope I was able to explain everything clearly, and if you have any doubts, please do revert back to me. Thank you.